Hello, everyone. This is Jessica Porras. I'm the Senior Manager for Education and Outreach here at CAQH CORE. Welcome to our October Town Hall. Next slide, please. I'd like to mention a few logistical items. The slides and recording will be sent to attendees and registrants in the next day or so. Right now, the only way to see our slides is to go through GoToWebinar. In addition, we will have time for questions at the end of the webinar, so feel free to add your questions at any time during the webinar by going to the panel that's on the right-hand side of your screen. Next slide. As you can see, we have a lot to cover today. We'll start out with an overview of CAQH CORE and industry activities. Then we'll go on to give you an update on our most current initiatives on prior authorization, electronic exchange of medical documentation, VEP, our operating rule maintenance work, and also core certification. Next slide. And now I'll turn it to our first speaker, CAQH CORE Director, Erin Weber. Erin?
Thanks, Jessica, and thanks everyone for joining us today. I'm going to give a really brief overview of CAQH CORE for those of you that are new to the organization. CAQH CORE is made up of participants representing 75% of the insured U.S. population, including health plans, providers, vendors, associations, government organizations, standard-setting groups, et cetera. We really represent a wide breadth of the healthcare industry. And our mission is to develop healthcare operating rules that support standards and accelerate interoperability and align the administrative and clinical activities between health plans and providers. In 2012, we were designated as the National Operating Rule Authoring Entity by the Department of Health and Human Services, and I'll talk about that in more detail in a minute. We are governed by a multi-stakeholder board, and we see our role not just as developing the operating rules. Many of you sit on our subgroups and work groups and contribute to the development of requirements, but we also see it as our role to develop and test and iterate and ultimately create a certification program for each set of rules where entities can demonstrate their commitment to the operating rules. We measure ROI as well as do a lot of education and outreach to the industry on key topics of interest like today's webinar. On the next slide, we've provided an overview of the current CAQH CORE operating rules and those that are in development. To date, we have developed operating rules for all of the HIPAA standards, including eligibility, claim status, EFT, ERA, claims, and prior authorization. And we are in the process of developing operating rules for attachments. The first three phases of the CAQH CORE operating rules are federally mandated, meaning that every HIPAA-covered entity is required to follow the requirements within those operating rules, and that's part of our designation as the operating rule author. A couple quick updates before we get into the details of each of our program initiatives. Earlier this month or late last month, we announced our new collaboration with HL7. HL7 is an ANSI-accredited standards organization, and our collaboration is really focused on improving interoperability between clinical and administrative systems. We've really prioritized three areas within the collaboration. The first is prior authorization and focusing on moving the industry towards end-to-end automation of prior authorization for various use cases. The second area is the exchange of medical documentation. Much of this is done manually at this point in time, but we will work together to align our efforts to support the electronic exchange of clinical information and medical documentation. And finally, we also see opportunities to collaborate within value-based payments. As the industry makes this transition, we will work together to address interoperability challenges that are causing administrative burdens for innovative payment models. And then on the next slide, just a quick highlight of some things going on at CMS. Earlier this year, CMS announced that they would be randomly selecting 9 HIPAA-covered entities, a mix of health plans and clearinghouses, for compliance reviews with the HIPAA administrative simplification rules. This includes requirements for transaction formats, code sets, unique identifiers, and participants will be required to attest whether or not they comply with the federally mandated operating rules that I mentioned a few minutes ago. That's eligibility, claim status, EFT, and ERA rules. Last year, HHS conducted a pilot program of this process, and this year they're actually conducting proactive compliance reviews. They have shared that the proactive approach implements a progressive penalty process with a goal of remediation. So they will work with entities to resolve any issues with corrective action plans. In the case of willful and egregious noncompliance, monetary penalties may be assessed and calculated on a case-by-case basis. They have also mentioned that this year they will be piloting compliance programs with providers as well. Earlier this year, CAQH CORE and WEDI collaborated on a set of 2 webinars with CMS to talk about these compliance programs, and we've included the links here for those of you that are interested in getting into a little bit more detail, including some written responses to Q&As that were provided during the webinars. So I encourage you to take a look at those. With that, I'm going to turn it over to Bob Bowman, my fellow CORE director, to talk more in detail about some of our efforts related to prior authorization. Bob?
Great, thank you, Erin. As we move over to the next slide, you'll see that there are very specific challenges that the industry faces when it comes to building a more automated system and environment for the adjudication of prior authorization. And we found much of this information from a lot of work that we've done over the last few years related to our surveys, working with the industry, doing provider site visits, really working to understand what these most significant challenges are. And they kind of fall into these 6 different buckets, basically. Everything from needing consistent data from across the industry. Every health plan may require something a little bit different. Provider systems are all a little bit different. There's no federally mandated attachment standard, so it's hard to actually communicate data that must be sent in with the submission or requested by the health plan. How does a provider do that? It's a little bit different for every health plan. A common denominator is a fax machine, so again, 1980s technology trying to address a 21st century problem, definitely a problem, right? A lack of integration between systems, right? A lot of providers have EHR systems now. They don't necessarily integrate with their PMS system or their administrative system. So how can we build basic data models, understanding what those models are, implementing that integration across systems? There's also a limited availability of vendor products. Many vendors are stepped into this space to help address the problem, but again, providers haven't purchased these systems or haven't implemented them systems, or the implementation is staggered, right? Certain products or services for some plans where other plans are still fully manual. Another problem for integration of a more automated system is that there are state requirements do require manual intervention. Many health plans adjudicate the request for prior authorization manually, and then actually request the submission of the data or additional documentation manually. Lots of phone calls are taking place, lots of fax machines are being, send buttons are being hit, so it makes it really a challenge for the industry. If we move over to the next slide, one thing that we were trying to do to address, we do have our first polling question here. We want to make sure that the industry is aware that, are you aware, basically, that HIPAA health plans are required to support PA electronic transactions if a provider requests to submit that transaction electronically. Again, we understand that many of the providers submit using a web portal or through a fax, but there is an electronic standard that supports this. We'll leave the poll open for just a few more seconds, 20 seconds or so. We want to make sure we give everyone a chance to answer this question. great. The results look great. About 73%, 75% are aware that this is a standard that must be implemented by health plans and can be submitted by providers to support the electronic PA process. And that really helps because if we can initiate the inquiry or the request for the prior authorization for a particular number for a particular service electronically, it really can speed up that process for the providers. So great, thank you for participating in the poll. If we move to the next slide, one thing that we've done to help help the industry understand where progress is at, where the industry is at, is that we published a paper in July of this year identifying the 6 topics I just reviewed, and particularly some of the plans that we can make as an industry, some of the steps we can take as an industry to facilitate a more automated PA process, addressing some of those challenges. Excuse me. So if you haven't had a chance to look at the paper, and it's been really widely received within the industry, with actually thousands and thousands of downloads, we're really excited about it because the industry can actually come together through the core operating rule process and actually look and walk through and try to understand the challenges first, and then what can we do as industry to address them through a staged approach. If we move to the next slide, you'll see that we at CORE, we do have a staged approach. We're looking at this through our many different processes, again, being our very vision and mission driven, as Aaron mentioned, that through our first iteration of our operating rules in phase 4, we address some of the basic components of the challenge for infrastructure and interoperability. And that means that we set up consistency for connectivity and security requirements. We ensure that there's system availability. The health plan has to be able to receive a transaction. We have very specific requirements around how to conduct the transaction. Building on to our next step in phase 5, you see that we've actually now cracked open the nut of the transaction basically and addressed some of the biggest challenges related to data content. So accurately identifying the patient, looking at very specific data requirements related to error codes and codes messages that come back to the provider so they know what the next step is. So if there's a requirement to submit an x-ray or a film or a piece of data, to be more specific in that request to the provider, so the provider knows exactly what to send. So they don't send everything, they send just that specific image, that specific file, that specific piece of data. So it helps simplify the adjudication process at the health plan. Additionally, we're continuing our work in our stage approach. If we move over, we have a subgroup that's currently considering a few additions to our rule set, and that means that we're looking at specific timing requirements for a final adjudication. Say, what is the requirement on a health plan to send back a final disposition for a prior authorization? Today, the industry is all over the place between different state requirements, different federal requirements for federal programs. Every health plan has different requirements they may set with their different employer groups as they're managing those books of business. So is it 15 days? Is it 30 days? Is it 24 hours? It's all over the place, and the burden's on the provider to actually understand what that requirement is for each plan, for each group that they might submit a claim for. So we're trying to come with a more consistent approach around those types of requirements. Additionally, we're also working with some of the industry leaders on pilots. The leaders that we're working with in the industry are dedicated to pursuing a more automated approach for prior authorization. So they've signed up with us, and we're working both with providers, vendors, and health plans to set up basic pilots on very specific use cases related to prior authorization. It could be selected types of service, categories of service, or service codes, very specific use cases that we can help drive some industry education, industry best practices, and some lessons learned around data connectivity, because it might be expanded beyond what we had in phase 2 or in phase 4 for connectivity. We'll get to that more in just a moment. But the pilots can help feed back that information loop to continue the industry's staged approach in addressing the challenges for prior authorization. I do want to note there that we do have certification available for phase 4. And so entities are going through that process now to ensure that they're in conformance and in compliance with the Phase 4 requirements, and Phase 5 will be available actually by the end of the year. If we move over to the next slide, continue our update for, really important. We are waiting for federal action in interaction. We'll be working with that, more of this in a little bit later, but we do want to make sure that the federal regulatory process is aware of the work that we're doing, and we're working with the rest of the industry to make sure that everyone is kind of aware of those too, as well. I did mention that we are updating the draft Phase 4 rules with some of the timing requirements. If we go to the next slide, thank you. We do have some draft updates to the Phase 4 rules. These do require very specific requirements around for the health plans to request additional information or documentation from the provider. How long do they have to do that? The time requirement for the health plan to send the final determination back to the provider, again, making it more consistent. And also a time requirement to close out a prior authorization if the requested information is not received from the provider. So those time frames, we're very hopeful for a more automated system or application to be built, both from a provider, vendor, and a health plan perspective. And also, again, it's those roles and responsibilities, those time frames, help set up certain expectations, again, leading to more of a national approach to how prior authorization can and should take place between a provider and a health plan. Really kind of reduces that overall adjudication time, helps people build systems to do this in a more automated way. Move to the next slide. Just as a quick update, I mentioned this on the previous couple of slides about our pilot program, but again, we are really trying to reduce the administrative burden from providers and health plans by applying existing data content and infrastructure operating rules to close that gap for prior authorization. And again, we have some of these industry leaders who are really looking at this in a really focused way to highlight those challenges again and find ways to actually mitigate those challenges. Again, using existing emerging standards and technology from X12 to HL7 to FHIR, rapidly applying the existing rules in their current system, right? So there is some development effort, there is some work that's being done to actually build the end-to-end PA workflow in a more automated way. It's really, really helpful to see this kind of in real time, and then we can report on what is actually working and what's not working. Where do we have to jigger this? Where do we have to move this? So those measurements of the impacts are going to be really, really important. These operating rules work really, really well here. Here we don't have an operating rule, so there's still this challenge. What can we do as an industry to continue to address this particular challenge? So that feedback loop is very important for us. And we also plan on recommending our rule sets to HHS so they can look at the work that we've done and potentially recommend this as moving forward as an industry to kind of, again, solve the challenges that we have with prior authorization. On the next slide, we do want to have a call to action for the participants on the call. Please start your planning efforts and working with your vendors if they do not have a PA solution or a solution for the prior authorization or the 278. Now's the time to actually start talking and working with them. We do have vendors that are going down this path now. They're testing. We have some of them that have already completed. So there's a list of folks that you can reach out to if you're looking for a more automated solution. We also want to make sure that you stay engaged for the prior authorization. Again, if you are in a position or if you want to participate in a PA pilot with us, we're looking for all stakeholder categories or groups, anyone from any of our health plans, providers, vendors, clearinghouses. We will work with you to get you plugged into the most appropriate pilot for where you're at and where you want to go. We have lots of folks that are engaged, so we can continue to work with you as well. And last but not least, we do have a participant-only Phase 4 webinar that we're going to review the Phase 4 rule changes and updates and edits that have been completed and approved, and we will do that as part as we prepare for our final vote. And we do have the final vote scheduled for November. So again, really important for us. Feel free to reach out to us. Now on the next slide, we're going to move into our second polling question. Which of the following areas within the PA initiative should we continue to focus on? Understanding when the PA is required, best practices for building auto adjudication, or defining a universal definition for an urgent PA, and what does that mean for both providers and health plans in that auto adjudication process. Give you a few seconds to select the ones that you think that we should continue to work on. And again, this is part of our staging process for as we build out our future work plans for, again, mitigating the challenges for our authorization. Give you just a few more seconds. And I think we'll be able to display the results. No, I'm sorry, I'm going to go in the internal prop. I'll hand the call over to Taha Anjarwala, our CORE Senior Manager, to walk us through the next part of our agenda, defining a path to electronic exchange of medical documentation. Taha?
Thanks, Bob. So when talking about attachments, there are many different definitions kind of used in the industry, and for the context of kind of CORE and what we're focused on, attachments really refer to the exchange of patient-specific medical information or additional documentation to support an administrative healthcare transaction. So it's really important to note that we see attachments that support a variety of different use cases, such as the need to send a treatment plan, to support a healthcare claim, or a lab result to obtain a prior authorization for a procedure. And further, attachments can be used for value-based payments and can include reporting for things like the need for measures for quality reporting. Additionally, oftentimes, for audits as well, a provider may need to send a full copy or a portion of the medical record to a payer to ensure that they're complying with the audit request. And the method of how attachments are exchanged between providers, health plans, clearing houses can really vary. It can be a manual process of printing out and popping the attachment into an envelope and mailing it in to fax machines, which are really popularly used today. And partially electronic methods, such as a web portal, also exist, where a provider can log in via online interface and upload an attachment, similarly like as you do an email or part of a medical record to the health plan. And with electronic, there's currently a lag of implementation, but we see that there's a lot of progress being made in the industry today with lots of different industry organizations working on moving the industry from a more manual attachment process to electronic. And CORE is really currently engaged in these activities and conversations to ensure that the attachment workflows from providers and health plans can really take advantage of completely electronic models. On the next slide, I wanted to highlight that earlier this year, CORE published a white paper that really culminated findings from a one-year attachment environmental scan. In this white paper, we outlined 5 different opportunity areas for the industry to focus on to really determine how to accelerate industry adoption of electronic attachment transactions. And these areas include workflows, data variability, exchange mechanisms, infrastructure, and resources. And I'll provide a little bit of detail on each of these. So first of all, workflows really map out steps and processes on how to accomplish tasks. And in the context of attachments, there are workflow types and these types vary across different use cases I highlighted earlier. And really, electronic attachments really require a bridge between administrative and clinical systems. So lots of different moving parts to make an electronic attachment workflow successful. We identified opportunities to reduce workload burdens by identifying, the need for clear documentation requirements, so identifying, what attachments may be needed at the time of a provider submits a claim or prior authorization, and also establish timeframes for operating rules, so that way there's basic expectations that are set within a workflow. Second, looking at data variability, which is really the degree to which data shared between parties diverges from various structures. And there's really 2 different challenges we identified in particular to this topic. One is related to the reassociation of attachments to a particular administrative transaction, which would be the inability to link the medical documentation to a claim. And this often leads to a lot of requests being pended or causes delays in the adjudication cycle. And kind of the second challenge we identified was the use of unstructured file types such as PDFs, Word documents, images, and how do we enable a more automated adjudication process and transition to the use of more structured data, such as the use of an HL7 CDA. So opportunities really are on this to improve upon this category would be to reduce the variability in attachment data and kind of try to progress the industry to use more structured and uniform data sets to really make it easier for health plans to keep attachments linked and also to automate the adjudication process. The third topic area, exchange mechanisms, really refers to how information is transferred between provider to health plan. Challenges with this topic is that a lot of organizations and stakeholders reported that they're waiting for the federal adoption of an electronic attachment standard, when this has really caused a proliferation of various options for attachment exchange, which kind of highlighted earlier. And there's really no consensus on what common standard or approach or data format to use for exchanging attachments. So opportunities that what CORE could do to improve on this area is really determining which sort of electronic method would reduce burden, such as the use of an X12 standard, the 275 transaction, or even the use of HL7 FHIR to really streamline and reduce the number of ways attachments are exchanged, and also to further try to reduce the reliance on manual methods such as mail and fax. The fourth area, infrastructure, really refers to the fundamental instructions on how data exchange systems need to work, such as connectivity, security, and also adding in basic communication protocols. Well, challenges identified with this area include the lack of integration between administrative and clinical systems, such as electronic health records and practice management systems being able to talk, connect, and share data with each other, and also the variability in timeframes and the receipt of acknowledgments in that an attachment has been successfully received. Really, opportunities to improve this area include gathering the industry to convene on common communication standards and also establishing basic expectations for response times within an attachment transaction. The fifth opportunity area, resources, are really single sources of truth. Utilities maintain further use of industry by industry, really along the lines of driving consensus to transparent documentation requirements, and also reducing the variability in how documentation files, so centralizing things into one place. So opportunities to improve upon this topic include, we've identified the creation of a standardized companion guide to ensure that requirements are structured and fall within a uniform flow, and also making available in a centralized way where attachment policies may be made, so a provider can go to one single place and know what attachment may be needed for a particular service. So with that, those are kind of the main takeaways from the white paper. And to really tackle the attachment challenge, CORE has launched a multi-stakeholder advisory group to really drill down on each of the opportunity area categories and really work to address the challenges that I talked about on the previous slide. And the goal for this advisory group is really to identify potential operating rule options that CORE should prioritize and move forward with future rule writing later on in 2020. The advisory group is currently active, and it's planned to complete its work efforts by January of next year. So in addition to the work being done by the Attachments Advisory Group, CORE recently launched an industry-wide survey to better understand the variability and utilization of various exchange mechanisms across the 4 attachment use cases of prior authorization, claims, quality measures, and value-based payments to really inform how we develop operating rules. The survey asked respondents to identify the use of different file formats such as PDFs, JPEGs, images, CDAs, and the exchange mechanisms which are used such as mail, fax, and EDI to really better understand how the organizations support the exchange of medical documentation. And further, the survey also drills down on the industry utilization of structured data like the HL7 CDA, and asked organizations to share how well the CDA today currently supports the needs for the industry across various use cases. The survey is currently active, and it's open for industry comment. So I believe it's closing on Friday, October 18th, so we definitely encourage the participants on the call to complete that survey. And you can access it via the link on this slide, or you can also reach out to CORE for more information. And lastly, I'd like to highlight all the various different attachment initiatives that are ongoing with CORE, and just try to get participation from everyone in the audience. So first of all, once the advisory group finishes their work efforts on really prioritizing different opportunity areas, CORE will be launching an attachment subgroup to really define the actual requirements that may be needed to support attachment exchange transactions across various use cases. So definitely need input from the industry and folks on this call to join that group. Further, we're also engaged in pilot projects, and Bob talked a little bit about this. So, if you're interested in partnering with us to engage in any attachment pilots, we'd be more than happy to facilitate that. And further, we also plan to host a variety of different upcoming webinars that focus on attachment as a topic to further educate the industry. So stay tuned and sign up for our mailing list for that. And lastly, want to make another pitch for the attachment survey that we had out. We definitely really value industry input on this topic. So with that, I will transition to the next polling question.
Thank you, Taha. So let's go ahead and launch the third polling question. As you just heard Taha describe the white paper we recently released and the 5 opportunity areas. So we'd like to hear from you, of these 5 opportunity areas, which one keeps you up at night, is the biggest headache for your organization. The white paper is available online if you're interested, and also Taha mentioned some education events. I'd also like to point out that all of our attachments webinars that we've had the last couple of years are available on our website. On the resource library page on our website, you can actually find our webinar series, including attachments. So I'm going to give the poll just a few more seconds, and then Taha, I'd like to share these results with the audience and just kind of get your take whether this sort of is in sync with what you learned when you were doing the research. Let's go ahead and share these results. So it seems like there's a few that have a little bit more weight than others. What do you think, Taha?
Yeah, so I think this really aligns with kind of the general findings and also the feedback we've received from our advisory group, and that, looking at data variability, workflows, and exchange mechanisms, those really are key priority areas on how you need to exchange the attachments, because there's no federally mandated standard, what transmission method should be used, and also, what should be the recommended format. So I think that falls in line with kind of the general findings, and we'll definitely take this feedback and share it with the advisory group, and also consider this for future education sessions as well.
Thank you, Taha. And so for the next webinar segment on value-based payment, I'd like to introduce CAQH CORE Manager, Lena Geber-Marian. Lena?
Thanks, Jessica. Next slide, please. So I'm going to be reviewing some of CAQH CORE's value-based payments initiatives. So if we go on to slide 25, what you'll see here is that CAQH CORE conducted over 2 years of research and identified 5 industry opportunity areas. These opportunity areas could smooth the implementation of value-based payments. We also found that stakeholder collaboration is critical to preventing the same sort of administrative roadblocks that fee-for-service encountered. So the CAQH CORE research focused on interoperability, so defining common processes and technical expectations, patient risk stratification, which would be promoting the collaboration and transparency of those models, patient and provider attribution, so improving provider awareness of this attribution and the transparency for the underlying models, quality measurement, educating on the consistent and actionable quality data while considering physician burden, and data quality and uniformity, standardizing identifiers, data elements, transactions, and code sets. The idea is that through industry collaboration, focusing on these 5 opportunity areas, a common infrastructure could be built that drives the adoption of value-based payment models. With hopes this would reduce administrative burden, improve the information exchange, and enhance transparency across clinical and administrative verticals. So earlier this year, CAQH CORE founded a VBP advisory group. Next slide, please. And in this advisory group, they prioritized 5 opportunities for administrative action within those found in the report. And so these 5 opportunity areas focused on by the VBP advisory group have sort of found different paths within CAQH CORE to move forward. So our first bucket, for those that are moving forward immediately, we have 2 opportunity areas that will be moving forward through a CAQH CORE subgroup. And this is our normal rule development process. So these opportunity areas are patient risk identification prior to the point of service. So helping providers understand where in the high, low, rising risk categories their patients are before they even have that appointment. And patient attribution status check at the time of the eligibility check. So at the point of service, when a physician is conducting an eligibility check to see if a patient is eligible for said service, is this patient also within their VBP population? The third opportunity area that will be moving forward will be through a potential pilot program, as Taha talked about in attachments and Bob mentioned in our prior authorization efforts. So this would be the inclusion of expanded code sets on a healthcare claim. The idea behind this is that the fee-for-service claim is very good at conveying what services were provided, but not what the outcome of those services were, which is the basis for many quality measures today. So if we could use expanded code sets such as LOINCs or CPT2 codes along with the healthcare claim, this could sort of move forward in the workflow that quality measure reporting and process reporting, and eliminate some provider burden when it comes to end-of-year reporting. These following 2 opportunity areas are very closely linked to some of the CAQH CORE efforts that we've talked about already today. So this opportunity area under Explore is explore the synergies with current CAQH CORE Discovery pilot. And this is the opportunity area of notifying exactly what additional documentation a provider needs to submit to a health plan in order to satisfy quality measures, care gaps, etc. So this is not a uniquely VBP focused opportunity area. This is a problem that's encountered across prior authorization, across healthcare claims, and therefore we're hoping to take the learnings from our prior authorization pilot and apply it to the VBP use case. And finally, the 5th opportunity area that our advisory group prioritized is the standardization of the exchange of additional documentation. So now that CAQH CORE has launched our attachments advisory group, we're hoping that the learnings from that group and perhaps the subsequent subgroup and those learnings for the VBP use case could actually align with the VBP advisory group's work here. So as I mentioned, 2 of these opportunity areas are moving forward to the CAQH CORE VBP subgroup. And the first of those opportunity areas is patient-provider attribution status. Here on slide 27, just to level set for a moment, when we talk about attribution, we talk about the method that matches individual patients in a population with providers. And this will ultimately determine the patients that our provider, either as that individual provider or provider group, is responsible for. So this forms the basis of analysis for metrics, quality measures, total cost of care, et cetera. And so health plans will often give providers sort of monthly or quarterly lists of who their attributed population is. But even when they get these lists on a regular basis, you're still left with several questions. So the first of those is, why are they in my population? So while VBP contracts will often outline what the methodology is behind such an attribution, clinicians who are providing the care often are not connected with those who actually sign the contract. And therefore, they may not know why a patient is in their population, especially if it's a patient without a prior relationship. Second important question is, who's on first? So if a patient's assigned either to an individual provider or a group of providers, it can sometimes lead to ambiguity as to who is the primary care provider responsible for that patient. Furthermore, patients with chronic conditions such as heart disease or diabetes might have a specialist who acts as their PCP, which may or may not be reflected in the attribution model. And those providers may or may not be aware of each other. Finally, an important question is who else is involved in this patient's care? So in that situation where you have a patient with a chronic condition who might have, say, an endocrinologist for a patient with diabetes who was acting as a PCP, a primary care provider might not be aware of their existence. And in some VBP models, providers are penalized when patients in their population visit other providers. So preventing this leakage is a large incentive in these contracts. But without visibility into the patient utilization, you're often unaware when this occurs until well after the contract period is over. So provider success under VBP models requires knowing the answers to all of these questions. But before asking these questions, a provider needs to know the answer to the most important question, which is this patient in my attributed population in the first place? And so this is the question that our VBP subgroup launching next week is looking to answer. Move to the next slide. We are now launching a VBP advisory group on October 16th, which we encourage all core participants to join. And this subgroup will take a look at patient-provider attribution and figure out how, in an electronic and standardized format, we can share that attribution status of a particular patient with a provider prior to the actual appointment. And furthermore, if that's not their patient, whose patient is it? And the hope is that we can do this with a singular patient or with a group of patients as well. So this subgroup will run through at least the beginning of 2020, and we encourage those of you who are core participants to join. And so the next slide, we'll take a look at the call to action. So again, please consider joining the value-based payment subgroup. It's open to all core participating organizations, and multiple individuals from the same participating organization may join. Specifically, we're looking for subject matter experts in provider patient attribution and those familiar with the HIPAA mandated transactions. And also take a look at the CAQH CORE resources on value-based payment. We've launched a new online interactive module to learn more about these key opportunity areas in VBP. And with that, I will go ahead and hand it on to Emily Tenike, our CAQH CORE Senior Associate. Emily?
Thanks, Lena. Next slide, please. We'll first start with maintenance on the Phase 3 EFT and ERA operating rules. And to level set, the Phase 3 rules include both infrastructure and data content requirements to address key payment and remittance advice processing challenges. These rules are federally mandated, except for rule requirements pertaining to acknowledgments. And together, these Phase 3 rules work to improve cash flow via expedited payment and remittance reconciliation. They eliminate the need for manual rekeying of reconciliations, as well as standardizing enrollment for EFT and ERA. And the EFT and ERA enrollment data rules specifically identify the maximum set of standard data elements for EFT and ERA enrollment, and they also require health plans to offer electronic EFT and ERA enrollment. The rules also address requirements on providers to specify how payments should be made. So these enrollment data sets will be reviewed this year as part of the annual maintenance process, which we'll talk about in more detail on the next slide. So Section 3.4 of the CAQH CORE EFT and ERA enrollment data operating rules recognizes the need for ongoing review and requires a policy and process to review the enrollment data sets on an annual basis. So the goal of this annual maintenance is to address emerging, new, or changing industry business needs, and there are two types of reviews that are conducted. So one is a limited review of the data sets, and this type of review addresses only those non-substantive adjustments. These are going to be adjustments that don't change the name, position, or collection requirements for the core required data elements, sub-elements, or the data element groups. So this type of review does not require changes to enrollment systems or forms. The other type of review is a comprehensive review of the data sets, and this review addresses both non-substantive and substantive adjustments. And substantive adjustments could be the addition of new or modifications to existing data elements, or it could be adjustments to rule language beyond the enrollment data set. So if substantive adjustments are approved, the HIPAA-covered entities are required to update enrollment forms and systems. And this year, the 2019 enrollment data maintenance process will consist of a comprehensive review, so that second type of review there. And this review will take place in Q4 of 2019. And CAQH CORE participating organizations will have the opportunity to submit potential substantive or non-substantive adjustments through an online feedback form as part of this maintenance process. And then the CORE Enrollment Data Task Group will then review the results of the submissions in early 2020. So we've included a link here to the CORE EFT and ERA enrollment data sets maintenance process webpage, and you can find more information there on the details of past reviews and key policies and procedures. So on the slide, we look at the core code combinations maintenance process, and this process addresses modifications to the set of required code combinations that convey the details of the claim denial or payment to the provider. We see on the graph here that the total number of adjustments from submissions to the market-based review has decreased dramatically over time, and this illustrates that core code combos are being used consistently by the industry and require fewer modifications that couldn't be addressed during those compliance-based reviews. The latest published version of the core code combos from the most recent CBR included only 31 adjustments, as you see on this graph. And this version was released October 1st for implementation. If your organization has an adjustment to the core code combos based on any changing industry needs, we do encourage you to submit suggested modifications via the MBR survey by end of day tomorrow. And the results of that survey will be published on February 3rd of 2020. And with that, I'll hand it back over to Bob Bowman to discuss core connectivity.
Great, thank you, Emily. And just as Emily mentioned, this is the section pertaining to our rule maintenance process. And we are going to be kicking off a rule maintenance process for our connectivity rule. As you can see, we've been working with connectivity and everything that means around interoperability with security, authentication, connectivity for over a decade. And we've implemented these rules, the industry has implemented these rules, both on a voluntary basis as well as through the HHS regulation for adopting phases 1 and 2. So with the wide industry base that has implemented our connectivity and security requirements, as we've progressed that to phase 4, we're continuing to look at the industry's needs for security, for authentication, for other modes and means for exchanging both clinical and administrative data. So we're looking at particularly REST or FHIR or other API-based technologies to help support that integration of this, again, clinical data and administrative data, and how we exchange that information between stakeholders. If we move to the next slide, you see we do have a plan for looking at and reviewing the process that we have in place, right? This staged approach that we have. We do hope to release a paper in November, so next month, that highlights the connectivity as a key driver for that foundation for interoperability. It will provide an overview of the various standards and protocols that enable connectivity, as well as our approach for aligning both existing as well as any future and emerging needs for healthcare connectivity. We'll be launching a connectivity environmental scan in the 4th quarter into the 2nd quarter of next year. So the 6-month planning process around where the industry is at, looking at the trends that exist, where the industry is going, looking at the technology requirements, security requirements, authentication requirements, because things have really changed quite drastically over the last really short time, last 3 or 4 years. There's been a lot of talk around different technologies. So how do we implement a process of reviewing, looking, and potentially including those types of requirements within our own operating rules? So we will be launching a task group to review the findings from that environmental scan mid-year next year and updating the core connectivity rule to address the industry gaps and make sure that we're aligning with those new opportunity areas. It's going to be really important for us for the industry to participate both in our environmental scan as well as the core participants to participate in that task group later this year. If we move over to the next slide, I want to continue this discussion that we started earlier with our call to action. We have a lot of things coming up related to our existing operating rules, beginning with our joint webinar with X12. It's going to be industry-wide, so you don't have to be a participant. Anyone can join, and we will be reviewing the EFT and ERA. Again, that will be November 5th. So check your email boxes for our registration link. We'll make sure that we get that out to you, and we can block your calendar to make sure you can attend. We will also have the core participants will be able to complete the EFT and ERA enrollment data comprehensive review survey that Emily mentioned as well. And we do have specific dates around when that will open and when that will close in November and December, and we'll be working with that task group to make any recommendations or changes to those data sets. We also have our core combinations task group. Again, as Emily mentioned, we do have a compliance-based review as well as our market-based review. Again, anyone in the industry can submit on our market-based review survey. It is still open. So if you're having particular problems or challenges with a particular code combination, does it make sense to you? Then it probably doesn't make sense to many other folks either. So let us review that as an organization that's tasked with this to update those rules, and we can help, again, continue to bring clarity to the particular issues that are challenging. Last but not least, we do have our connectivity environmental scan that I just mentioned for the first part of next year and the latter part of this year. Again, we'll be reviewing and working with industry representatives. Again, you do not have to be a core participant to understand where you're at, what you're doing, where the challenges are. With that, I'll hand the call over to Taha for a review of our core certification program.
Thanks, Bob. So I'd like to just kind of give a brief update to kind of key updates to the certification program. So, but before I begin, just want to provide a background of core certification for those that may not be familiar in the audience. So core certification really offers cost savings, industry recognition, and market advantage for organizations that exchange healthcare transactions. The certification program is really designed to ensure there's a streamlined exchange of administrative transactions by aligning IT systems with the federally recognized and industry-developed operating rules. The program is really an industry gold standard. So on the next slide, you can see that not only does the core certification program track adherence to operating rules and standards, but it also drives and tracks market adoption of rules and standards as well. And to date, we have awarded 368 certifications across phases 1 through 4. And the charts on the slide really illustrate the penetration that those 368 fields have on various market segments of the healthcare industry. By the end of 2019, we're projecting to have greater market share penetration within phase 3 of certified lives, so on the EFT and ERA transactions. We expect that coverage will be nearly over 50% across three of the 4 market segments highlighted on the slide. On the next slide, we hear that many of the reasons why organizations get core certified, it's kind of based on the idea that, there's third-party testing and also that it helps organizations really demonstrate conformance to the rules and standards that are meant to be used. And this really can result in a $12.4 billion saving potential for the industry. And as we heard earlier from Aaron in the presentation, CMS is now kind of live with their compliance review program, and entities are selected to participate in this program really must attest to compliance with those federally mandated operating rules and also are tested with compliance with their underlying standards as well. So core certification can really be used as a tool to help organizations prepare for these compliance reviews and audits through its comprehensive certification testing and application process. Core certification is positioned to help organizations assess, demonstrate, document, and certify conformance with federal mandated standards and rules and help build confidence at an organizational level and a compliance level in the event of an audit. On the next slide, I'd like to highlight some key enhancements we'll be making to the certification program in 2020. So we are adding in a requirement for recertification, and we believe that with evolving technology, healthcare consolidation, and system upgrades, there's really a need to assess ongoing conformance with operating rules to really maintain program integrity. And further, we believe that recertification enables organizations to align with healthcare needs for rules and when requirements are updated over time. And in building out our recertification program, we convened together a multi-stakeholder focus group consisting of core certified organizations to gather insights on key policy decisions for recertification. And some of these key policies include that we plan to launch the recertification program for any newly certified entity beginning in 2020. That some organizational certification status will remain for 3 years. So every 3 years, an organization will then have to renew their certification. Further, if an organization fails to complete recertification or there's a lapse in time for that renewal, CORE will then go through a process where we can start revoking the CORE seal to really ensure there's integrity and maintenance of industry compliance to the rules and standards. And lastly, any new updates or adjustments to the core operating rules will then be incorporated into the recertification process. So those are key policy changes. What we expect more, and we'll announce more, and we'll engage the industry as the program comes further develops and more into end of this year, earlier next year on key changes. And we'll also reach out individually to each of the core certification stakeholders to really talk through what the impact may be. So with that, I will hand the call over to Jessica for the next polling question.
Thank you, Taha. So let's quickly launch this last polling question. And this polling question will really help us with our planning efforts for next year. So if you're considering core certification, either this fourth quarter or early next year, if you need more information, please answer this poll. We won't share this information. This really is for our own planning efforts. And then for those of you who answer no because you're already certified, thank you so much. We hope you see value in core certification. Let's give this a few more seconds, and then we'll just close the poll and move on to our Q&A. I know we are running out of time, but I'd like to take a few questions from the audience. Let's go ahead and close and move on to the next slide. So we have received a couple questions. We received a few questions regarding the pilot, and I know that Bob and Taha both talked about it. So the questions were, one, what do we need to think about as we're considering doing a pilot with CAQH CORE? And the second part of the question is, what do they need to do if they're interested? So Taha or Bob, would you like to take that question? Those questions?
Sure, I can jump in, and Taha can add anything that he wishes to. One thing that we found that's been very helpful for pilot participants is that if they have a particular use case or a category of service, so if you are a specialist provider or you're a hospital that has particular system or service that is causing more problems, or it's more automated than others, right? It's kind of like, where do you want to go? So we're trying to meet both providers, health plans, and vendors where they're at, and then kind of nudge them about considering first measuring how they're currently doing the system or the process, what that process looks like. Is it taking 12 days? And we can wrap around some operating rules or better data content or better messaging to the provider, and it reduces down to 7 days, right? So we're trying to have some good measures in place, both pre and post, as well as if they're just an environment that you're in that could be helpful for the industry at large to better understand the needs, the problems, or the challenges. And then applying operating rules through a vendor solution or through a better connection or a better data exchange with a particular health plan that you may have a direct connection with, right? The means and modes of transmitting the data would like to interview you and understand what that really means. Again, if you're interested, we've included our email address, but it's core@caqh.org. go ahead and email us or anyone on the presentation today. We can reach out to you and kind of understand, do a quick call, interview you, and make sure that you're a good fit. Again, just about everyone that we've encountered is a good fit. We can find someone that can help you and help us and help the industry actually understand the challenges and then how we can best mitigate them.
Thanks, Bob. So we have time for one more question, and then I think we'll have to end the webinar, unfortunately. So there's a question for Taha. A couple people asked when core certification for Phase 5 will be available.
Yeah, so Phase 5 certification should be available by end of this year. I'll probably say around late November, early December timeframe. But if your organization is interested in pursuing Phase 5, feel free to reach out to us. We already have a lot of resources available to help start with the planning. We have our analysis planning guides, we have our FAQs, we have our rules published. So, if you're interested, there are things that you can do to help get your systems ready. And then that way, when certification Phase 5 is ready for launch, you're ready to go with certification testing. So feel free to reach out if you're interested.
Thank you, Taha. So I know that some of you still see the poll question on your screen, so I'll just walk you through the last couple slides, and when you receive them in the next day or so, you'll be able to see some of the resources that we have available, the benefits of core participation, as well as some of our upcoming webinars that we have coming up. Thank you so much for joining us today. Have a great afternoon.